Hello, and welcome to Let's Talk SADS Live, the Canadian SADS Foundation's monthly webcast. I'm your host, Dr. Shu Sanitani, and delighted to be coming to you today from Vancouver. It's February, it's Heart Month, and very excited to be continuing in our programming. It started now just over 2 years ago. And this is a place we come together to learn together about SADS conditions, sudden arrhythmic death syndromes, conditions. And these are rare diseases that affect many of you, many of our audience, and have impacted your lives. And so we come here together to learn from people from all over the world and share in our knowledge. So um, excited to be here on Heart Month, and I'm going to share a screen here. Um, I'm feeling very technologically challenged today, so uh, thanking our good friends Alice, Laura, and Aaron Waite from the American SADS Foundation, who are of course huge supporters and helping us, and um, and part of our partnership with the American SADS Foundation. So as you can see, we're going to be talking about Brugada syndrome today. But before we get into that, a couple of reminders. So as many of you know, Pam Husband started the Canadian SADS Foundation uh, about 30 years ago now. It's hard to believe. And so in honor of Pam's incredible contributions to the Canadian SADS Foundation and having Canada represented really at the international forums, uh, we are happy to support Pam's Legacy Fund. So head to the website and you can make a donation to support Pam's Legacy Fund. So as I mentioned, February is Heart Month, and it's always a nice time of year for us. I work in a children's heart center, so we often uh, highlight heart disease during February and try and raise awareness. And so, sudden cardiac arrest is something that a lot of people have never thought about before until it affects their lives suddenly, coming into their lives often unexpectedly in seemingly healthy uh, young people, children, young adults, people doing ordinary activities that they've done thousands of times before, uh, sometimes at work, sometimes on the recreational activities, sometimes athletics. And these sudden cardiac arrest events are always very important uh, in the community, tragic outcomes sometimes, and thankfully good outcomes. And here's the message today is that you can really impact the outcomes by becoming a CPR trained and advocate for automated external defibrillators in your community and in your public buildings, in your schools. Uh, Vancouver has been in the news recently with their desire to get automated external defibrillators into one of the school boards. So there's still lots of work to do in getting these life-saving devices to you. And I feel like Heart Month is a good month to have that reset to say, how is everybody's CPR currency and AED awareness? So that's how I like to celebrate Heart Month and think of the power of saving a life. Very grateful to have some great partners in our programming here, and we've seen these names in a couple of different ways. We've seen them, of course, in our webcast, but also in the trials that are getting going. And so Lexio, Solid, Tenea, and Thrive, they're all doing very groundbreaking uh, phase 2 and phase 1 trials in new therapies for sudden arrhythmic conditions. And so things like gene therapy or new molecules where you, the patient, now is really at the center of these innovative treatments. And we're, of course, grateful to be able to do programs like this and other educational activities to promote SADS awareness. So for those of you who have been with me for the last couple of years, you know I like to have a bit of facts and fun facts or factoids. We started the program with some Canadian historical facts, and then tried to do some interesting things about SADS conditions. So this year I'm trying a slightly different spin of Canadian contributions to the SADS landscape, and so here we have the Brugada syndrome in Canada, a unique French-Canadian experience. And as we're going to talk about today, Brugada syndrome is often not thought of as a particularly cold climate condition. It's often more prevalent in Southeast Asia and the Mediterranean regions. But this paper now a ways back, 2007, highlights the experience in Quebec and French Canadian populations, and they, like many others, feel that it's probably under-recognized, and certainly the awareness has improved in our last 15 years, but still a very important cause of sudden cardiac arrest. So with that said, I'm just going to sneak ahead to next month. We're excited to have Dr. Robert Avram join us next month, and we're back to our schedule of the third Tuesday of the month in March. And Dr. Avram is a AI specialist, and so there's lots of talk and buzz about AI, but not all of it can be relied upon. And so we're going to dive into how to spot some of these things. Now, back to today's guest, and I'm very excited to bring in Dr. Georgia Brugada. She is a wonderful colleague and friend, an international expert from Spain, and I'm going to go through some of her story with her, so I won't belabor that at this point. So if we could bring her in, and I will stop sharing my screen. And Dr. Sarkea Brugada, and I will only try that mispronunciation once or twice. I'll call you Georgia. Thank you so much for joining. I will tell our audience that Georgia is still at work in the evening there, and obviously a very hard worker, as one of the only specialists in her region. So thank you so much for coming.
Thank you so much, Shu, and it's a pleasure being here. It's a pleasure joining SADS, but not only SADS, but SADS Canada. Part of my training has been in Canada, and Canada had hosted me especially well, and I've always been felt very welcomed in Montreal where I trained, and of course tous les Québécois, je vous embrasse très fort aussi.
So let's talk a little bit about that, your background. So how did you come to be where you are now?
Well, I'm a pediatrician myself, and I did my training in pediatric cardiology here in Barcelona, actually in the hospital where I'm working at. And then I moved to Montreal at Saint-Justine to do my training in interventional in congenital heart disease. Though that training was 2 years training, and part of it it was also at the Montreal Heart Institute. We were doing this kind of transversal learning, which I think it's very interesting. And then move back to Europe, this time at the Necker in Paris, and then back to my hometown. And here, even though I came as an interventionist, there was a gap on pediatric electrophysiology, and I had the big privilege to be next to Dr. Georgia Brugada, and one of the persons that have trained more people in this world, I think, in the world of electrophysiology. And I had the privilege to be also a fellow next to him, and then just to dive in the world of pediatric inherited cardiac diseases. And that at the beginning was nothing. It was a very small work here because it was not recognized. And I think this is one of the fields that has improved the most in the last year, all the genetics background on that. And we have been growing with it. In fact, you and me, we have been learning from the first diagnosis we were doing, like trying to have a genetic to get a sample or to get genetic analysis, like being in a favor, like knowing that somewhere in the world we're doing that gene, a specific gene, and sending a sample overseas. And we have seen how this field has changed, has grown, has developed up to now that we are already talking about gene therapy, which this is amazing. I mean, very few specialties in this in cardiology have overcome in such an evolution. And I think we were in the first row, being not only spectators but also part of it. And I think that's amazing. And now doing a gene panel, it's something so easy, but for the ones we have struggled for every single gene to get checked, I think we really learn how beneficial is that and how important is that. So I think that I've just traveled the world. I'm back home here, which is Barcelona, amazing city, and but also having a lot of friends just Zoom call away to just to be ready to keep growing, keep learning, and keep training as well. So yeah.
Yeah, no, thank you. And you've touched on a lot of important things that I will come back to some of them. I want to speak to the obvious one, and you've already mentioned Josep Brugada. So people in our audience are probably wondering and saying, is this a coincidence that Dr. Brugada is talking here? So just tell our audience here how you are in fact connected to the eponymous Brugada brothers.
Well, in fact, they are my mom's brothers, so they are my uncles, and they are adult cardiologists. And more or less, I would say that I'm more the pediatric part of this whole family matter, which is inherited cardiac diseases and electrophysiology. And I think that having the pediatric part of it is such an important, just to close this overall project, which I think it's the fight against sudden death.
And so, and interestingly, the first report by the brothers Brugada did include more children than we think of Brugada typically, and so as always, that paper always stands out, and we've featured it here in our show before. Let me ask you, because I find, as a person who, like you, we've been learning this field together in a rapidly changing world. Around 2004, genetic testing became, commercially available. So what do you think of as Brugada syndrome? Is it structural heart disease? Is it channelopathy? Is it both? How do you kind of think of it?
Well, I think this is a very important point, too. I think we've always also learned about it, and I have a theory that there are, I would say, two types of Brugada syndrome, and this is not written in any book. It's part of own experience. I think that as you mentioned correctly, the first case with Brugada, it was a child, a 2-year-old child, that his sister had died of sudden death, and he was having collapse during fever. And actually, these were like the first case, and the sister described in Brugada in the first abstract presented in a congress. 2 out of 4 patients were children. And in the first paper, the ones from Journal of American Cardiology, JACC, in 1992, that's a while ago, 5 out of 8 patients were children. So that type of disease that were described there, as it always happens at the beginning when a new disease is described, we put on the table the big ones. I mean, the very symptomatic presentations. And what is really very symptomatic when the disease is very severe and you don't need to go through a whole life to present the disease. It's so severe that even it presents at the first decade of life or even before. So those were like the real, I would say, real Brugadas, okay? And we think that in pediatrics, either we deal with those types of very severe ventricular tachycardias, very severe phenotypes that present in a major way, or either we go to the other side of the rainbow, which is just those patients, children that inherited or maybe not the disease that was diagnosed by chance in the father while doing an ECG for a no matter what surgery or whatever. And that's a disease that never gives, oh no, never, but that it's something, it's, I would say, diagnostic by chance. And this is a complete other disease. And I think when sometimes we put all of them together, we are a little bit confused. So, and I'm going back to your question, for those patients that present at very early in life, like 2 years of age, 3 years of age, and we see the ECGs, there is no doubt. It's horrible ECG, what we called white QRS, like, the little lines in our ECGs are amazingly abnormal, okay, that no one doubt. Sometimes it's so abnormal that we don't even see the typical pattern. It's because everything is abnormal. Those, of course, they end up having structural disease because the electricity is not moving on the right flow, on the right road, and everything moves as it can. That's completely different to the ones that at basal status, they have a normal ECG, which the electricity goes normally. And these probably we will never see nothing structural. For those, the early cases, we see structural because actually the heart is not bumping, it's not moving the way it should be. And at the end, this is not good for the movement of the heart. So I think that what is first? Well, I don't know. This is a very Spanish set. Is it first the egg or the hen? So what is first? Is a structural that gives electrical abnormalities, or is electricity going in not normal roads that provokes a structural disease? So that's difficult to say, and I think it's a mixture of everything.
So just one technical point, we've lost your focus a little bit. You're sort of out of focus right now.
I'm moving too much. That's a problem.
But there we go. So, but yeah, no, and it's interesting as you were describing this, it reminded me of other SADS conditions where we sort of accept that there is a severe pediatric phenotype or disease expression, and then a milder older, like almost every CPVT, we know that catecholaminergic polymorphic ventricular tachycardia, long QT in the neonates and infants compared to the older, and Brugada as well. And let me just understand a bit. When you say structural, do you mean actual like congenital heart disease, or just that the heart muscle is abnormal?
There is no evidence of abnormality in the heart muscle. There's no evidence of that. But it's true that, just I open parenthesis, okay? When you put a pacemaker in a child and it moves normally, but you put a pacemaker and you pace from a different side, you end up having movement abnormalities, okay? So, and at the end, you have what we call remodeling, so the muscle change the shape and the way it moves. So when your electricity, going back to Brugada, is not going where it should be going, the movement, it's abnormal, so it ends up remodeling as well. So of course, there are new findings now. We have gone through new discoveries in Brugada, even antibodies, immunological response, and a structural disease. But normally, we don't see that the cells in the heart are absolutely normal, but they move weird, and then it can provoke a remodeling, and that's very important. Having said so, we recently published a case report, which when we publish a case report, it means that we find one single case that there was an association with a valve of the heart abnormality together with the Brugada syndrome. That's by chance two rare diseases in the same person, which it means that Brugada patients, if we can publish one case, it means that 99.9999% of the cases they have normal structural heart and they don't go with structural heart disease or congenital heart disease, which are the holes and the valve which are not well developed.
Yeah, and I think, for many of us now in the recent years, I think a lot of us are assessing the structure when we see a new young child with Brugada. They will often get an echo, maybe even MRI. I'd like to touch on the big point, and because of the numbers of Brugada syndrome being very biased towards adults, so most of the people are adults diagnosed in their 20s, 30s, 40s. So most people that are out there with Brugada syndrome have a milder form or a fairly safe form. When, exactly as Georgia says, when we first learned about the syndrome, though, we were very scared, and lots of people got implantable defibrillators just when we found the diagnosis. So we thought, this is a very dangerous condition, and thankfully it has become safer as we realize how many people are affected. I want to talk more about the children, so especially these the 1-year-old, 2-year-old that are fortunately rare. In your experience, do you do genetic testing, and do you usually find something, or is it not usually informative?
Well, this is a very good point. In fact, the what we call the rentability, the chance of having a positive genetic result when doing a genetic study, in those cases is very high, because in fact they are very related to the sodium channel, which is the most common channel, and even the guidelines say it's the only gene that we should check when we think about Brugada, which is the SCN5A. That means the subunit 5A of the sodium channel. And this is the most common one. In fact, when we do a genetic study, which sometimes is easier to do a whole panel, and then suddenly we find other things there, we really, much of the time, we don't care about those other things, and we focus on just that gene. And the positive test, the chance of having a positive test when doing this genetic test in a very young child, because they are already having the abnormal ECG, is very, very high. And I'm guess that in the Canadian population is the same, right, Shu?
Yeah, no, absolutely. And we know that the Brugada syndrome is associated with a positive genetic test, only, somewhere between 15 and 30%, the number ranges. But in these particular young patients with a very, evident and significant case, then they're much more likely to have this sodium channel abnormality. And I will say, I will acknowledge the paper that Michael Golub led. Michael Golub, of course, is a Canadian leader in SADS genetics, and he did a very nice study of all these other genes that come up when you look for Brugada syndrome, and very few of them, if any, have enough evidence to support them. And Andrew Landstrom recently, with the SADS US Foundation, also sent out a nice paper looking again at the genetics. I think in general we agree that most of Brugada syndrome is what we call polygenic. So, we need probably a few different genetic variants, and that's why it does run in families, even when we can't find a genetic marker. So I find it one of the more complicated conditions, SADS conditions, in terms of the genes. Now,
absolutely, sorry, I think that that's a very important point, and the fact of sometimes people that they get their genetic test, the genetic result negative, they say, oh, I don't have Brugada. In fact, the chance of having a negative genetic test is higher than a positive genetic test, and that does not mean you don't have Brugada. We haven't found the genetic reason for the expression of your disease, and that's very important to have in mind. So sometimes I collaborate a lot with poorly developed countries, and sometimes I get these second opinions about people that they don't have much money and they have to pay from their pocket, and they say, oh, okay, I will earn money, or I will use my money to do a genetic test because my child has, or my husband has been diagnosed of Brugada syndrome. And I say, no, don't use that money for that. Use that money to do a good follow-up, and that's it. But there's no reason. It's going to change nothing. The diagnostic of Brugada syndrome is by ECG, by symptoms, and the follow-up. That's it. And there's no point on overdoing on that, because the rate, and it's not going to change our paradigm on what we are doing, and that's very important.
Yeah, no, thank you for making that. That's such an important point, because sometimes people wonder also, oh, they had genetic testing 5 years ago, should they repeat it? But again, the genetic testing and the way we do it currently is not informative. Now, one of the many challenges with Brugada syndrome, and I don't mean to overwhelm our audience thinking that it's such a complicated condition, but I do find it fairly complicated. It doesn't always show up. So you can have an ECG one day that is completely normal, and the next day the ECG has an obvious Brugada pattern. And one of the big triggers for this is fever. So I'm curious how you manage your patients with Brugada syndrome in general. Like, are you putting defibrillators in them? Are you using quinidine? And then specifically sort of your fever strategy.
Okay, that's so important. I think that's the most important point in Brugada syndrome in children. We know that fever is like kind of the not the red flag, but I would say that the moment of higher susceptibility in children with Brugada syndrome. So why is that so important? Because, as we said before, the sodium channel is like the door, the entrance door to the cell for the sodium, which is so important to keep our cells in a good balance, a good electric balance. The door does not work really well, and that's the sodium channel. That channel works so. But when temperature is higher than 37 degrees, which I don't know in Fahrenheit, but so when you have fever, let's say, the configuration, the conformation of this door changes, this channel changes, and if it was kind of not perfect at normal temperature, when you have fever, this configuration changes and it gets it closes like abnormally, let's say. Okay, so the current of the ions, the electricity through the cell, it's abnormal. Okay, so you increase your disease, or the expression of your disease, it's higher during fever. Okay, so that's a vulnerable point. And that's why we say, okay, it's so important that you control fever. Of course, we do not need to run to the hospital because we have a little fever, just because if we treat the fever and we give whatever antipyretic treatment and it goes down, but then 3 hours later, of course, it goes up again because your viral infection or whatever infection you have is there, and it will take a while to get rid of it. You need to control that fever with alternate ibuprofen, a paracetamol, or and do a good dosage of anti-fever drugs. Okay, but if there's no way, even if you give good doses, and if you go, you take a bath, a warm bath, or not some warm bath, and you do all the physic methods to just low down the temperature, and there's no way you can do that, and it's an uncontrollable fever, then that's a good moment to go to the hospital, because we have drugs and medication that we can give through an IV line, and so they are more active or more aggressive to control that fever, because we know that this can be a weak point on Brugada patients, and that's important. So we are 37.2. We don't run to the hospital. We are going to get more viruses in the hospital than at home, and that's important.
Yeah, no, and just a point, Canada does use the Celsius scale, so hopefully all of us understand. So a fever,
Okay.
and we don't worry so much about 37.5 or so, but absolutely, 38, 39. And in children in particular, I think the last, several children who have presented with Brugada syndrome, it is because they have had a fever, and their ECGs really change a lot. So, thank you for bringing up that excellent explanation that how our ion channels behave. Some of them are very temperature sensitive, and the sodium channel in particular is one of those channels. So now you mentioned an excellent strategy for fever management, and that that is very important. Do you use quinidine? So quinidine, for those in our audience that may or may not be that familiar with it, is actually a medication that we used to use a lot more for adult heart rhythm conditions, which essentially became obsolete until people discovered that it was actually helpful in stabilizing some of these channelopathies. So, do you use that medication for Brugada syndrome, or have you any experience?
Yes, we use quinidine. It's not frequent that we need quinidine, but we would use quinidine for those patients that we call a persistent type 1 ECG. So those patients that all the time they have an abnormal ECG, and we know that actually having the ECG pattern, it's one of the moments that it means that the expression of the disease it's higher. So the more time you have the pattern, the more time you are in a little bit higher risk, and that's it. So those patients having an permanent pattern, abnormal ECG pattern all the time, and that we know that they might be vulnerable because there is a strong family history, and that we know that they come up with a lot of fever, but sometimes it does not depend on fever, but they have a strong pattern. We might consider quinidine in when there is a strong family history of arrhythmias. Of course, if this patient has had arrhythmias during fever and it's a persistent type 1 pattern, we will consider other options, which are placing an ICD that I'm sure that we are going to talk about it now. So for those patients, being asymptomatic but having a permanent pattern and having a strong family history, we put on the table the possibility of having quinidine as part of our treatment strategy.
And before we go to the ICD, the implantable cardioverter defibrillator, I want to ask about two other investigations that I think we in the field are often wonder about, or even don't know the right answer. One of them is whether we should give what's called a provocative test, where we give a medicine that actually acts on the sodium channel to see if a person has Brugada syndrome. And I know you're having a debate in a few weeks on this topic, indicating really that it is something where we don't 100% know the answer. Are you using sodium channel provocation in your practice?
Of course, yes. Actually, in the debate in the American Congress, I have to defend the cons of doing that, and I will struggle a lot because I am trying to do my storytelling on how I'm going to defend the cons of doing that, but I will manage. The thing is that yes, I come from a long time school of knowing about Brugada syndrome, and we are very pro doing the provocative test, but in certain conditions, and that's the important. It's not provocative test for everyone. We would normally never perform a provocative test before puberty if the ECG is normal and we have no symptoms. So 4-year-old, which we see because daddy has a Brugada syndrome and the child is 4-year-old, no symptoms, so no febrile seizures, no epilepsy, no syncopes, no palpitations, and ECG is normal, we do nothing. We do ECGs once per year, and that's very important. We give a paper saying, please do me an ECG while I have fever. So they can take this paper to the hospital or to the general practitioner to have an ECG done during fever, because we know that the best provocative test to see ECG to unmask the Brugada pattern is during fever. And I say that, if we've gone through the worst of it, which is fever, and your ECG is normal, I'm really peace in mind. I have peace in mind, okay? So that's before puberty. And when we say puberty, why puberty? Well, because we know that hormones have a strong role in Brugada syndrome, especially testosterone, which is not only related to males, but also to females. Females also have certain amount of increased amount of testosterone after puberty. So after puberty, and we say puberty with big puberty, like no, because we have a little bit of a mustache. Huh? No, I'm telling puberty. We offer to have a provocative test done, knowing two important things. We use ashmalin, which is a drug which is like there are 3 or 4 drugs that can be used to unmask the pattern. We use ashmalin, which is the best of them, that has given better results on unmasking it. And if there is a negative result, we are pretty comfortable of that negative result. So that helps us to say, okay, you are 16-year-old, we've given you ashmalin, your ECG, which is a 5 minutes test, okay? And during those 5 minutes, there has been no change in your ECG. Most probably, you don't have Brugada syndrome. We have given the drug that blocks your ion channels, and there's nothing that changes. So most probably, you don't have Brugada syndrome. And we send this patient home saying, okay, have a safe life, have fun, bye-bye, okay? And that's the most satisfying moment in our lives, okay? So there is, then when it's positive, for us, there is a high confidence that that's a positive test, meaning that I have given you something that blocks the channel, and while giving you this, you have developed clearly the Brugada pattern, okay? Clearly, no doubts, the known type 2, type 3, no, type 2, type 3, it's not Brugada, it's like the clear type 1 Brugada pattern. For those cases, we are comfortable to say, yes, you have Brugada syndrome. And with that, we say, okay, you need to follow up, we need to do an ECG, and we need to know how fever acts with you, because you are not taking ashmalin during your normal life. Huh? This is not something you go to Starbucks and get an ashmalin shot. So we see ECG, and we tell you, okay, just avoid those drugs that might be similar to ashmalin, which are the list of sodium channel blockers drugs, and avoid those because we know that they may unmask you the pattern. So and we control fever, and that's it. And that's pretty simple. Okay, we've performed, and there is an extra thing which is not part of the guidelines, but we realized after several years that for those patients having Brugada syndrome during pediatric ages, during puberty, I think there are many changes, like in general for everybody. And growing is one of those changes. And while growing, we need to get used to our new body. And not everybody succeeds with that. We have a lot of faintings, a lot of unknown dizziness, a lot of palpitations, and a lot of many things that we all know, that we all have been adolescents and teenagers, and it might be very difficult. So what's wrong there? That if you have been diagnosed of a Brugada syndrome, and suddenly you have one of those faintings which are related to puberty, but you have a Brugada syndrome, nobody knows if actually you have had an arrhythmia, and then all the red flags start, like all the red lights start like beeping there, and everybody gets very nervous, because the first thing we think is that those patients have had an arrhythmia, malignant arrhythmia, and everything is a big mess. Okay, so our strategy for the last, I would say, 5 years here, that we have offered the families to implant a subcutaneous Holter, which is a loop recorder, a small device that we put under the skin, very small device, that like larger as a paperclip that we put under the skin, and it's a Holter. It just has certain alerts. I would say that if you go lower than a certain heart rate, higher than a certain heart rate, or you have an arrhythmia, the device registers that. Does nothing. It just only registers. No? We can have a nice registry of a very ugly arrhythmia. And by then, actually, our goal is not to diagnose asymptomatic arrhythmias. Our goal is that when you have a symptom, whatever it is, we want to rule out there is a cardiac origin on that. So with that, we know that we have seen that by doing that, we cool down the stress related to whatever syncope or loss of consciousness in a child with Brugada syndrome. We have decreased the amount of visits at the hospital, and we have decreased the number of defibrillators that we have implanted, because, of course, those cases that were not clear were cleared up. And that's very important. And actually, we published that recently. We did a multi-centric work, and we managed to get information from several hospitals in Europe. And the largest amount is our center, because we have a large number of children with Brugada syndrome. And we have been analyzing the impact of doing that in life quality as well. So it is important just to rule out that whatever symptom, like important or not, we can rule out and clear that there's no cardiac origin on that. So we have a lot of peace of mind once again.
That's I'm looking forward to reading that study. That sounds very important, and I just want to highlight a couple of the things, really excellent points you made. First of all, that fainting, common fainting, and heart sensation of heartbeats skipping or fast heartbeats are very common, much more common than relatively rare conditions like Brugada syndrome. So that we have to bear those in mind and sorting through them. And then just the other point that's, I think, very important is, and I hope our audience is appreciating this, the nuances we're talking about. And you said, type 2 and type 3 is not Brugada. So there are different ECGs that can appear, and one really needs expert evaluations. And especially in pediatrics, there are a few normal variants that can be fool people, a fake Brugada. And these are very common. And so, I can't emphasize enough the importance of seeing, specialists in SADS conditions and inherited arrhythmia experts. And of course, the Canadian SADS Foundation is in partnership with those. And I'm sure in Europe there are also some very good networks of people. We are just about out of time, and rather than ask you the ICD question, because you sort of answered it by saying, we can avoid some ICDs with good other strategies and data. I want to ask you one last question about exercise, because some people have said, the Brugada syndrome is, can be triggered by fever, and so, but exercise also raises the body temperature. Especially a soccer match in Spain, I'm sure can get to supra to above normal temperatures. What sort of guidance do you provide your patients about activity when they have Brugada syndrome?
Okay, that's a very good point. I'm telling all my Brugada patients play football in Spain. So why that? The body is very intelligent, and the temperature, the grades that you raise during a very hot day playing sports, it's not much. The body knows the way to just cool down that extra heat that we are giving, and exercise is not contraindicated at all. I would say, is it contraindicated? Is it contraindicated to do sports in the middle of the Sahara Desert and dehydrate? And no, of course, but it's important that we need to do all the warming up and the hydration and so on, and that's it. But there's no contraindication. It's true that there are certain patients that during the recovery phase after an exercise test, we see that we can unmask the pattern, and that's another way to unmask the pattern during the recovery phase for those patients who go from 180 during running, which is great. I mean, we have no restriction on that, and then they go to 55. On that bradykardicization, sometimes we unmask the pattern, and that's another way that we can check. So overall, we are in a very good situation, and I would say, and you don't need to take medication, and that's a good point of Brugada. So I think that overall, from all the channelopathies we have, actually, having been diagnosed of a Brugada syndrome at age 35 because of an ECG performed and for another reason, being asymptomatic, and it's easy. Just you avoid certain drugs, you take care of your fever, that's it. You don't need to take medication, you can do sports, there's no restriction in your life, and so on. So this is a pretty easy one, right?
Well, Georgia, this has been a wonderful opportunity to talk with you. You're such a wise and experienced practitioner in all SADS conditions. So I've enjoyed our talk incredibly, and I'm sure our audience has learned a lot. And certainly, I think the message is, pediatric Brugada is very different from most adult Brugada, and that's something that we as pediatric cardiologists are often experiencing, that children are not just miniature adults. So thank you so much, and I look forward to seeing you at your debate, which I'll have the privilege of watching. And we will absolutely look forward to reading your publications about this, the loop recorders. Thank you so much.
Thank you, Shui. It's been a pleasure. I really appreciate being with you this evening, and I hope that we definitely will see each other in San Diego, but I hope that we can see here over that sharing with our Canadian colleagues as well, and help as much as I can on that. Thank you so much.
All right. Thank you. What a great source of information and real practical experience on a fairly infrequently encountered patient population. So it's been an absolute pleasure, and as always, I'm learning as much as our audience is in having these wonderful guests. So just a reminder, next month we're going to venture into some technology and some learning. I'll have to do a lot of prep work to understand what AI means, and that'll be March 18th. And please check out the website. www.sads.ca, and we can support Pam's Legacy Fund, and also check out some of the information that we have there about the various SADS conditions and resources there. So thank you so much for joining. I'll look forward to seeing you next month.